Um, I'm going to turn this over to Dr. Kristen Jacobs, and she's going to get this kicked off for us. Welcome, everybody.
Yes, welcome everybody. Then welcome to Ivy League Learning on this fine Wednesday. That is right, correct? Wednesday evening. Yay. Tonight, our topic is the importance of turning DIVAs into prolonged dwell peripheral IVs. DIVAs into PIVAs. Is that how I was? That's read nicely. I love that. So tonight we have Dr. Shears with us, and who's come to speak at AVA many times. He's a pediatric intensivist and anesthesiologist with a long-standing interest in vascular access and reducing patient complications. And then Tanya Stevens, where I don't know where she went. Oh, there she is. There she is. Tanya is a vascular access specialist that practices at Chesapeake Mobile Health in Maryland, Virginia, and DC. And she was previously the president of AVA just like a minute ago. So welcome to both of you, and I will turn it over to you guys to get started.
Thank you.
Very good. So I'm going to share my screen, put this up, and go like that. Should be slideshow now.
There we go.
Did that work out?
Yep, that did. Thanks, Greg. So thanks everybody for joining us. We are going to talk about the importance of turning our DIVA patients into a prolonged PIVA, which is a peripheral IV access. So we're going to start out by talking about what a DIVA is. Oh, here's our objective, excuse me. So we're going to just talk about a few things. What the DIVA is, we're going to describe steps to how we're going to transfer these DIVAs into a PIVA, and then understanding what tools that we need to consider to have in our toolbox so we can accomplish these.
All right. Well, so what is a DIVA? So the word diva has been around a really long time. Diva in Latin means goddess. So not exactly what we would associate it with. And in the English language, diva didn't really exist until the 19th century, when people would apply it to the best opera singers or the cinematic stars. And in modern day, Mariah Carey probably is thought of as one of the biggest divas, both in the sense that she has an amazing voice. A little trivia for you. She can sing in a full 5 octaves, including the whistle octave. And there's been only a few singers that can do that. And the other thing is she's also known for being rather demanding and particular. So she fits the diva title quite well. So that's one way, one definition of diva, but of course we've got something else in store. And this article that begins to define some of the parameters. It's a prospective cohort study analyzing 339 catheter insertions from back in 2005 and looking at those variables that influence insertion difficulty.
So this slide here, for those of you who might not even be able to see it, actually breaks down what those variables are. And a lot of this we see on far too regular basis. So the rolling veins, the not visible veins and the non-palpable veins is a big complication for our bedside nurses. The awkward locations is always a problem. There are just plenty of patients who really don't have any good access at all. And that's a complication for all of us. And then we start talking about their skin integrity, whether they have the tough skin, if they have fragile skin as they get older, what is the color of their skin, and then the resistance to being punctured. You know, how are their electrolytes? Are they a dialysis patients? Are they previous chemo? Do they have LOs, downloads? So what plays into that? And their obesity or their BMI as a total, are they excessively thin or have a lot of subcutaneous tissue that kind of plays as a havoc for some of our veins?
So in vascular access, we have sort of grasped onto this DIVA acronym, in part through the Ken Yen study from back in 2008. He's an emergency medicine physician practicing there, and he did the so-called DIVA score. Well, when you're doing vascular access, the typical vascular access paradigm is going to be that interplay between the patient, the clinician, and what equipment the clinician has available to them in order to perform the vascular access. And any one of these three items can obviously influence the success of that venous access attempt.
So the main factors that affect the patient themselves, some are controllable and some are uncontrollable. Patients really can't change their age or their genetics. Theoretically, they can't change their skin pigment, but we do know that people tan, people do bleach. The ones that are a little bit more controllable are IV drug abusers. If we can get them to stop early, that would be grand. The BMI, again, if they're overweight or underweight, is a huge complication for us as inserters, but ultimately the patient. Medical conditions, our sickle cell patients, our chemo patients, our renal patients, these tend to be some of the bigger ones that we see. Volume status of our patients when they arrive, or maybe we've depleted it one way or the other. And their temperature, a patient can come in one way, but their temperature can change, whether they become septic or just febrile and their veins are very shallow and then they get chilled and it drops down for us. So a lot of factors that play around the patient themselves.
And the interesting thing is, let's say that a patient had reasonably good veins and then was unfortunate to be in a car accident and had a significant hemorrhage. They could have gone from an easy access to a difficult access purely by that change of volume status over the course of hours following the accident. So with regard to the clinician, there are a number of factors that influence our ability to be successful in achieving access. Are we wearing our glasses today? Do we have color vision? How much sleep? Were we on call all night? And then now we're asked in the morning to go start access. This happens to me all the time at the end of a shift. Then, oh, would you please help us over here or there? What is our mental state? Are we going through a divorce or is death in the family or something like that? Time pressure. Well, you've got all of these patients that are needing help, but you've got to focus on the here and now. Is the patient cooperative? This is really important with pediatrics, the ability to either do chemical or other forms of physical restraint to help them be still so that you're able to have a chance to achieve access. Location support makes a big difference. So for example, in my practice, if I'm up in the regular ORs, piece of cake, I've got access to really good quality ultrasound, near infrared, all kinds of toys. But if I have to do what we call outfield access, starting cases down in the MRI or CT areas, it's very challenging because we're much more limited from an equipment standpoint. And then, of course, we bring our bigger circles, our experience, our knowledge, the memory that we have from going to conferences and things like that, and our ability to have consistency with our sticks and equipment.
So our equipment in and of itself is a big factor for all of us. And sometimes we don't get to pick what type of devices we have at our facilities. Sometimes we have the benefit of ultrasound. I hope that a lot of our bedside nurses have the ability to use near infrared. But again, these aren't always readily available. Tourniquets, believe it or not, if you don't know, tourniquets are very different from one to the next. Some work a little bit better than others. Some use tourniquets. Some people don't use tourniquets at all. And then it is the device itself. How sharp is our needle? The trim from the tip of the needle to where the catheter actually enters the vein. How long is that? And, Greg and I were talking about this the other day, and a lot of people don't realize that from the tip of the needle to where the catheter actually enters the vein is different on a variety of different catheters. And if you hadn't had the chance, really take a look at that as you move forward. And then the tapering edge of that catheter, does the end of your catheter towards the needle head taper down, or is it a blunt ending? You know, what material is your catheter actually made out of? And does your device offer a wire to help get into that vein a little bit more securely?
So DIVA, what is it? Is it this simple interaction of the patient, clinician, and equipment? Not really. It's much more complicated than that.
So in this picture, we have the DIVA, but did the DIVA start on its own? Was it the patient that became a DIVA? Was it the equipment that we used that started to damage these veins on these patients? I mean, think about our oncology patients, how much they get stuck, our sickle cell patients, how much they get stuck, how many times our pediatric patients get stuck and then they have to grow up. Or is it the clinician? How well were you trained? How well do you see others trained? And we all work environments where we see people who maybe don't perform to the best of the ability that we'd like to see them perform. And are they blocked by something different? You know, in the patient status, you can have a pediatric who's uncooperative, or you can have a demented patient who's uncooperative. In the equipment, again, sometimes we're limited to what type of devices our facilities are willing to bring in, or just how well are we trained. I know when I was first trained to use ultrasound, I think I was exceptionally poorly trained, and I almost didn't want to use it because I didn't fully understand what I was seeing. And as I train other people, I kind of see that factor in them in the beginning. So all of these play in a factor of who is a DIVA and why they became a DIVA.
So as I was reading and preparing for this, I came across this quote, which I thought was very insightful and something that I've believed for a long time. The ability to predict DIVA is best done assessing whether the patient has a history of DIVA, and through examination reveals a lack of accessible veins. And this is something, those of you that have gone to any of my presentations related to, let's say, near infrared, you know that I speak to this topic. The assessment of venous favorability based on visibility and palpability by the operator has been used as a predictor in other studies. So I don't think that scores per se are as valuable as point of care assessment and having the appropriate equipment in order to gain access in those patients.
So taking a DIVA to a prolonged well DIVA, how do we do this? Well, we have to have the skills and the knowledge within the clinician themselves, whether it be the bedside clinician or the vascular specialist. We really need to have an optimal site choice. Again, we know to stay away from the joints and the sites of sensitivity that would be moved too much. We don't want to be going through muscles. We want to find a good site that's going to last long on that patient. If possible, and whenever possible, we need to be using near infrared or ultrasound on these patients. And when I say these patients, I truly mean every patient that comes to a facility. I know it's not always realistic, but the more we can use them, the less damage we can be causing. We want to have the right equipment. So we really need a device that has a sharp needle. I very much like using a wire. I like that added confidence that it gives me, plus that security. I like a tapered catheter. Again, I like to cause the least amount of damage to the vessel as possible. Aseptic technique needs to be done. We want to prevent infection. We know that that triad all links together when we get an infection, that the vein is getting damaged. And proper securement and a proper dressing is imperative on everyone. You can place the best device, but it can be easily removed if it's not properly secured.
Absolutely. So how should hospitals deal with DIVAs? So like Tanya was mentioning, I think it's absolutely necessary that we assess before we access. So prior to attempting access, we thoroughly assess. I'm particularly keen on using near infrared, and I think it's one of its strongest qualities because you can do it rather quickly. It's not perfect. It's faster than, your eyes and the fingers in doing a thorough assessment. But if we're going to try to quantify how many veins somebody has, because in reality, we probably have to triage patients, or we should be triaging patients in 3 different categories. One would be the genetically lucky one that has veins everywhere. I mean, you just look at them without a tourniquet and they've got all kinds of great veins. And then there's the in-between ones that they have some veins, you can find them, maybe some hand veins or other. And if that's appropriate for the type of access that they need, great. And then lastly, there's those patients that are either known difficult access or really don't have any obvious good veins. Those should be saved strictly for people with skills and equipment. The in-between group probably should be used with either the highly skilled, more senior nurses or other that are able to manage that, and the naive earlier learners should probably stick with the more obvious veins. And in that way, hopefully we would be sticking patients a lot less. So we have to understand the patient's history related to vascular access and also what their access needs are at that time. So spending a few extra minutes going through the records, well, what problem do they have and how long are they going to be in the hospital and what sort of medications are they going to need? Talking to the primary team would be ideal. So the facility protocol should identify vulnerable patients with limited targets, and that should be an automatic referral to vascular access. It shouldn't be the 2 and 2 and 2 and 2. It should even happen before the stick. We have to pull the trigger to get the vascular access specialists involved earlier. Near infrared and ultrasound can both help convert, visually speaking, a difficult access to an easier access in the sense that you can see more viable targets. And lastly, technologies such as integrated wires within catheters can help increase the success, and longer catheters can help improve dwell time. So that's really the sort of package. If hospitals really wanted to do something about reducing sticks and prolonging dwells, those 5 items really would help them get there.
So we talk about challenges with IV placement. We know that it's a 2.1 average attempt, and this is really related to the bedside nurse. We know that the multiple attempts, it just creates greater complications within the patient. It's a higher cost. It lowers our success rate after these patients have been stuck multiple times and they finally call the vascular team. 15% require 3 or more attempts. And when you think about that, that's just a horrible thought process, because I don't even like to be stuck 1 time. So what do we really call somebody who's a difficult access? Is it a one-time deal or is it an ongoing thing? And unfortunately, a lot of times we make it an ongoing thing. You're not considered or labeled a difficult access until we've had problems with you multiple times. And I think it's something that we as vascular specialists need to correct moving forward. And the dissatisfaction rate, we concentrated on that a lot when Medicare, Medicaid came out with that. And I don't think we put enough emphasis in it. I wish it was stronger questions after patients were discharged from the hospital, because we can really improve that rate if we can improve their vascular access.
So we want to thank Sonostic as the sponsor for this webinar, and Ivy League Learning. And the Sonostic device is a really kind of a clever way to deliver a wire. It mates with an IV catheter that has an open flash chamber. It then drives a wire down through the needle after one is within the vessel, and extends that wire equal or greater than the length of the catheter itself in order to help deliver that catheter nicely into the vessel. It is able to keep the wire sterile because it has a sterile packaging on the back, and it's a one-handed operation, which is perfect for trying to do a sterile insertion. So it feels good in the hand. It's nicely balanced, all of that.
So
Tanya?
basically it's done with kind of a 1, 2, 3 steps. So you insert the catheter, which is a catheter over the needle, into the vein till you get a flashback. Then you advance the guide wire, and that helps you make sure you have purchased the vessel, all 3 layers, with a nice blue wheel that helps you to advance it forward. And then you thread the catheter over off the needle and over the wire into the vessel.
We're going to show you a very brief video. I'm going to talk through it, and then we're essentially done, and we'll take questions. So this is something provided by the Sonic Stick company to us. They had no influence over this presentation. So they're just showing an open back catheter and needle. The device itself then has this clever green thing that goes over the blunt end of the needle that's in the flash chamber, and it securely mates onto that flash chamber with that white portion. And then you're able to advance the wire. So you first test to make sure that docking process is good. And then when you're using it clinically, inserting the catheter in the normal way into the skin, you see the flashback, or if you're using ultrasound, you see the needle in there. You can then nicely see the wire advancing within the vessel and deploy it fully. And when the wire is in, it has a stopper on the back, so you can't lose the wire in the patient. So the wire stays within the device. You deliver your catheter, pull out the entire needle and wire, and dispose of it in a safety needle disposal container. And that's it. So we want to thank you very much for listening in on this presentation, and we're very happy to take any questions you might have.
Thank you so much for that presentation. Is there anyone in the audience that has any questions? This I haven't seen this before, Dr. Shears. It looks like a neat.
Yeah, it's quite a clever thing. So this is a device that was developed by some emergency medicine physicians, and they liked the arrow device used for arterial lines, but they didn't like the fact that it was a two-handed technique. And because they wanted a single hand technique so they could, with ultrasound insertion, be able to do it. And so they came up with this concept, and it's a good concept. It feels good in the hand, and so it's one-handed delivery of the catheter. So it's a pretty cool thing.
The benefit is it's one hand, whether you're doing it with or without ultrasound. So you can even release your tourniquet if you're a tourniquet user while you're still doing all of this steadily.
Awesome.
We have a question in the chat. Is it much more expensive than the current ones?
So it's going to be a little bit more expensive than the arrow device for arterial lines, but it's less expensive than some of the other wired devices on the market. So they're trying to hit that middle ground of, it offers a lot more than the old. I don't mean that in a disrespectful manner. The arrow device, I've used a million of them. I've put in so many arterial lines with that device. But it provides a lot of advantages to the clinician. We're having to pay a lot of attention to hospital obtained bacteremias, hospital onset bacteremias. And so we want to do everything as sterilely as we can, but we can't do maximum sterile barrier for everything. So the ability to manage a wire one-handed with this device and deploy the catheter for difficult access or challenging access, it's really nice that it keeps the wire contained within the device, and we can deliver it without losing it in the patient. So it's kind of a nice combo that way.
Okay. Sheila has her hand up. I'm gonna go ahead and ask you to unmute and you can ask your question.
Hello, I may have missed it, but I was wondering if the when after you access the vein or the vessel, does it? I saw where it said don't retract the wire once it's past the needle, but does the needle retract as well when after you
No.
advance your catheter? Okay.
So basically, it's advised to just advance your wire before you ever put it into the skin, just to make sure that there's no issues. You don't want to get in there and be wondering why your wire is not advancing, if in fact that may happen, because all kinds of things happen. And, you know, obviously, if you're in between layers, your wire won't advance easily. So you'll know it worked in the beginning. And once you're in the vessel, anytime you advance a wire outside of a needle, it should never be retracted back until the needle comes out. So I don't know if you were able to see the video or not, but when you saw the device being pulled out of the catheter, it looked like it was coming forever. And it was the needle and the wire already expelled outside of the needle itself. So it looked like it was dramatically long, but it's the whole device coming out. So you would not retract it back once the needle's in the skin.
Okay, so there's no safety device on the needle.
So the wire itself functions as a partial, at least, safety mechanism, in the sense that the you did, for the one that you saw, so that with the diagram that, or the animation that you saw was like with a Gelco type of catheter. The one that it's going to be paired with has a passive safety clip on it. And that catheter does have a safety mechanism that will be present. So yes, it does come with a safety mechanism with it. And the wire that is exposed adds additional safety, but the tip is already covered.
I'm gonna go ahead while we're answering up questions. I'm just gonna put a poll up for you guys to answer in your free time. We're trying to find out what students we have involved at this presentation. So if you guys just want to answer that while we continue talking. Does anybody else have any questions? Anything regarding the product or the presentation or anything else? Okay, then I think we're good. We want to thank again Sonostic for sponsoring this presentation, Dr. Shears and Tanya for providing this information for us. It's been fantastic. Thank you all for joining, and we hope to see you next time.